Okay, so good evening, everyone, and welcome to this BOS Rising Star Round 1 Trauma A session. So today we have the trauma talks presented by our contestants. I'll invite Dhar sir for introducing the concept and the topics. Dhar sir.
Yeah, thank you, Ashok. Good evening, everyone. Once again, we are here for this episode of Rising Star BOS Bombay Orthopaedic Society. Today, the session is on trauma. I welcome all the participants, Dr. Nitish, Dr. Varun, Dr. Dhruvi, Dr. to this trauma session. I also welcome our esteemed judges, Dr. Satish Mutha, Dr. Sachin Kale, Dr. Ashish Phadnis, our Honorary Secretary. And, I welcome Dr. Bijlani also. So as you all know, you are all aware of the guidelines and all the participating rules. Today's session is on trauma. You have already been assigned your topics. So we have the judges here. We judge you all. So I thank you all for participating in this. And BOS is always at the forefront of promoting young blood and giving them permission to uh, present their own presentation skills as well as research skills. And I hope and wish your progress in future and become part of regular academic activities and all those. I hand it over back to Ashok to tell you a few briefly about the rules and wish you all the best for today's session.
Thank you very much, sir. I'll invite Dr. Neeraj Bijlani to introduce the judges and the rules of the contest today.
Hi. Yes. So today we have the trauma session one, and there are a lot of presenters today. And for them, we have called a lot of our judges. So the first judge is the Secretary of the Bombay Orthopaedic Society, Dr. Ashish Phadnis, who is the Director of Orthopedics in Jupiter Hospital in Thane, Mumbai. The second judge is hopefully the future President of the Bombay Orthopaedic Society, Dr. Satish Mutha, who is basically a consultant trauma surgeon, and he's a specialist trauma surgeon. He's trained so many people and he has helped out so many people during surgeries, including one of them being me. And third or fourth are my very good friends, Dr. Harshad Argekar, who's an associate professor and head of unit in Cooper Hospital. We have done our VIROC 2017 together, and we have been secretary and treasurer of the Bombay Orthopaedic Society in the last 2 years. And last but not the least, Dr. Sachin Kale, who's the professor and head of unit of D.Y. Patil Hospital. And he is he is in last 2 years, he has achieved so much. He has written books on trauma, arthroscopy, arthroplasty, and now he's going to write a comprehensive book on, he's editing a comprehensive book of textbook of arthroscopy and also the monograms which will be released in VIROC. So with this, I hand over back to Dr. Ashok to take over and start the proceedings.
Thank you, Dr. Neeraj. Uh, as the contestants know the rule, it's 7-minute presentation for each, followed by 3-minute question and answers. And you'll be judged based on your presentation skill, your review of literature, and how you answer your questions. To the judges, all the contestants are being given topics and they have been asked to do a literature review on the topic, not present their own cases. So they are going to present only synthesis of literature to you on the given topic. So you have to mark accordingly. So they're not presenting any clinical examples as such. With this, we start our session today, and I'd like to invite our first contestant, Dr. Nitish Sharma. Dr. Nitish, please share your presentation and we can start with it.
Yes, sir. Sir, am I audible? Hello?
Yes, you are audible, but share your presentation. We can't yet see it.
Yes, sir. How do I share? Uh,
Neeraj has to take one more class for sharing the screen. Maybe you can,
Yeah,
Ashok, you
click.
can help him. Yeah.
You can click the green button down on the Zoom panel and
Yes,
then
sir.
start sharing.
Uh, sir, am I sharing now? Is it?
No, not yet. You have to share through Zoom, not through PowerPoint.
Sir, there's a green one button which arrow one, right?
Yes. So click on it. Whatever opens, you can see your PowerPoint also. Or you can share the desktop and then share the PowerPoint. No worries. Whatever works.
Sir, they're asking me to grant permission for the same. Like, can I just like take 1 minute? Like, I just need to.
You have to update your Zoom.
No, no, I'm in Zoom app only, sir. But they're asking me to grant permission to share the screen. As soon as I click on the share button.
You are on a MacBook.
Yes, sir, I'm on MacBook.
Yeah, so you need to do the entire process. So maybe meanwhile we can start with the second contestant, Dr. Pratik Rathod. Rathod Pratik. Pratik, you're here?
Yes, sir. Am I audible?
Yeah, you can start.
Is my screen visible?
Yeah, your screen is visible. Just go full screen.
Yeah. Is my screen visible now?
Yeah, it's
Yeah.
visible, but it's in
Yep.
middle of the presentation. You can start.
Yeah.
Okay,
Uh,
I'll time your presentation and you can start now. Go
yes, sir.
ahead.
Good
This is
evening.
Dr. Pratik. All the judges, please note this is Dr. Pratik. Okay, go ahead.
Yeah, good
Yes.
evening, everyone. So my topic for today is extra-articular distal tibia metaphyseal fractures 4-3A. We are looking at the risk of malalignment between intramedullary nails and plates. So we're particularly looking at 4-3 A1, A1 to 3. So A1 is a simple fracture, A2 is a wedge, and A3 is a complex fracture. So distal tibial anatomy is quite notorious because it has minimal muscular attachments, thin skin, it's more prone to trauma, and skin is often involved because of the poor blood supply. The common issues in distal tibial fractures are non-union, malunion, infection, stiffness, and implant prominence. But we'll be particularly looking at the risk of malalignment. So it's defined in majority of the papers that are reviewed as varicovalgus deformity more than 5 degrees, anterior or posterior angulation more than 10 degrees, rotational deformity of 10 degrees, and shortening of more than a centimeter. Approximately 5 to 30% of nailing distal tibia which were nailed showed malalignment. The Shyam imaging used in these cases is not entirely reliable because it is difficult to control the malalignment in these closed surgeries. And if there's residual malalignment after this, it can alter the loading of the adjacent joints like ankle and knee, resulting in and predisposing to osteoarthritis. So we're looking at particularly two modalities, intramedullary nailing and plating. So intramedullary nailing, as we know, is it avoids soft tissue disturbance and protects the vascular supply. However, the challenges faced are for correcting varus valgus and procurvatum because we're putting a nail in a small distal fragment with a wide medullary cavity. So it may lead to high rates of malunion, knee pain, and secondary procedures. Plates, on the other hand, are more reliable in providing alignment, but as we know, they are notorious for wound complications. However, the recent MIPO technique can bypass these complications. So to avoid the malalignment, we can use certain methods like polar screws. So the literature review says the angle stable multidirectional distal screw and blocking screws in these fractures can maintain reduction, alignment, and prevent malunion. The other technique is a suprapatellar nailing. So as we know, the distal tibial fragment is can displace while reaming or inserting the nail in regular nailing. in infrapatellar nailing, but suprapatellar nailing, as the knee is kept in only 20 to 30 degrees of flexion instead of 70 to 80 degrees, it prevents the displacement of the fragment. Other methods which we can use are percutaneous clamps, distractors to avoid malalignment. The role of fibula fixation is controversial. One of the studies from 2017 says there's no difference between the plating and the nailing group in terms of fibula fixation. Another study from 2017 says there was no improvement in the treatment of distal tibial fractures. However, one study says the fixation of fibula with plate was significantly associated with maintenance of reduction beyond 12 weeks. So in this example, as we see, the nail was put in, but the distal tibial fragment was in valgus. But when we plated the fibula, the alignment was maintained. Another example, the alignment of the distal tibial fragment was not correct in the AP and lateral view. So in the revision surgery, after fibula plating, the alignment was much better, preventing malalignment. So in my review of literature, I reviewed around 20 articles. In this article, this was a systematic review of 8 studies consisting of 455 patients. They found that plating was associated with a lower risk of fracture malalignment, 8.7% compared to 24.9% in the nailing group. But there was no conclusion about the effect of fibula fixation. Same study. Another study from 2016, they concluded that angular malalignment was more common with infrapatellar intramedullary nailing versus plating. And regarding fibula fixation, they said the fixation of fibula reduced the risk of tibial malalignment in the future. Another study involving around 911 patients, they also concluded that MIPO was superior in preventing malunion. One of the studies, they said the overall rate of malalignment in any plane was around 30% with nails. Valgus was the most common deformity. They concluded that if the nail is more medial distal, more anterior distal, it was associated with a higher risk of valgus and procurvatum deformity. So they recommended the nail to be in center or slightly posterolateral target position. Another study is concluding the same thing. The nailing was associated with higher risk of malunion, and indirect reduction techniques in plate fixation resulted in similar rate of malunion. Similar results, another study. So this study they studied the effect of the lateral distal tibial angle and the anterior distal tibial angle to know the malalignment risk in suprapatellar versus the infrapatellar nailing technique. And they said only in the coronal plane, the difference was statistically significant, whereas in the sagittal plane, there was no statistically significant difference. The more and more recent studies are coming up, which are concluding that nails versus plates, like MIPO plates, there is no difference between the rate of malalignment. The studies after 2022 especially, they say there's no difference in the rate of malalignment. This was an interesting study, around 23 years back. So they compared the rate of the rotational difference between the two sides, and they concluded that the right tibia usually was more externally rotated than the left tibia in the natural knee, in the natural leg. So a 4 degree of difference was what they considered in the baseline tibial torsion, and accordingly, so this reduced the rotational malalignment in the fixation in the fixed tibias from 36% to 29%. This was another radiologic study where they studied the angle formed between the tibial plafond and the distal screw. and they found this to be sensitive in reducing the occurrence of malalignment. So tips. So from the review of literature, the tips to avoid malalignment were the nail should be in center in both AP and the lateral planes. Reaming should be only done in reduced position of fracture. The nail length should be till the subchondral bone. Additional techniques like polar screws, reduction aids should be used. The bigger the nail diameter, the better. Plates, although they reduce the risk of malalignment, but they cannot be done if the skin condition is poor and they cause soft tissue damage. These are my references.
Thank you very much, Dr. Pratik. I'll
Can I-
invite the judges for questions. Satish sir, you can go ahead first.
Well presented, Dr. Pratik. So what I conclude from here is with the newer nail techniques, it is the difference is negligible, right?
Sir.
With the latest study of 2022 that you presented. Am I right?
Yes.
Hello?
Yes, sir. Am I audible?
Yeah.
Yes, you are audible.
Yes.
Oh,
You can
now
stop sharing your screen.
Yes.
was there any study that you found significant which which compared the role of fibula fixation in achieving proper alignment and whether the fibulas were comminuted and non-comminuted?
I did
Any clarity?
I did present a study which compared the effect of fibula fixation versus no fibula fixation. So
there were two studies which you said there was no difference and one which said there is an important difference.
yes,
So what was your take on that?
the literature is still very divided between the two groups. Some of the literatures that they say fibula fixation prevents long-term malalignment risk, whereas the other studies said there was not really any difference in the malalignment risk.
Sachin sir, you can go ahead. Harshad sir, you can follow.
Yeah. Pratik, good presentation. I want to ask you when you will not nail the tibia, the distal tibia.
In cases of 4-3A fractures, sir.
Hmm.
4-3A fractures are
Okay.
extra articular. If the fracture is 4-3, maybe B with an interpartial articular component, or 4-3C, or if the distal fragment is very, very small. So one of the studies said if the distance from the plafond to the fracture is less than 5 centimeters, the distal fragment in these cases are very small. So in these cases, it is very difficult to control the alignment.
And any level of the fibula when you fix, like, and you said there is a controversy in the fibula. The same question, because the fibula is a lot of controversy.
Yes.
But if there is a fracture at the same desmotic level or below that, so it is advisable to fix the fibula or not at all?
It is advisable to fix the fibula in those cases.
Because this was not mentioned in your presentation. And any last question with a very little bone, like something, do you have ever seen nail and plate in the distal tibia fracture?
I've seen reduction plates, small reduction plates to control the alignment on the medial side, and then nail was passed. But talking about proper locking plates with the nail, I've not seen.
Okay, thank you.
So, Pratik, have you heard of the fixed DT trial which was done in the UK?
चलो you to ask my question. मेरा question पूछ लिया तूने यार.
ठीक है, तू ही पूछ लेना मतलब. So the question is, have you talked about the fixed DT trial which was held in the UK, which is a kind of a similar trial where they compared plates and nails, and they have drawn certain conclusions. Have you included it in your study?
No, I'm sorry, sir.
It was a big trial, a huge number of patients. The conclusions were more or less similar as to what you have drawn. The advantage of nail is that there was an early rehabilitation as compared to plate, but at the end of 6 to 12 months, most of them were at a similar level of recovery as well as complications.
Yes, there were many other factors like anterior knee pain if the patient wants to do kneeling, but my presentation was mainly on malalignment, so I did not mention those things.
All right.
Pratik, so I was going to refer the fixed DT trial again. One of the findings of fixed DT trial was to do with economics. Okay. So which one in your this thing wisdom would be a cheaper option to do, the nail or a plate?
Nail.
Nail. And so what I wanted to ask, are there so many studies you have quoted and really good journals you have quoted? Does anyone mention about the learning curve and what state of training the surgeons were? Where the surgeons surgery is being done by residents, or whether senior surgeons wanting to nail, junior surgeons wanted to plate? Was there any bias or any discussion regarding that?
I didn't come across any study like that, but one of the studies they mentioned that if the surgery was done at night or during the weekends, there were more cases of malalignment.
Malalignment. And did they mention any risk of implant failures? So if there has to be an implant failure, it would be common in which group? Nail or a plate?
For plates.
A plate. I mean, is it? I mean, I'm asking if your reference of.
I
I'm
don't
not asking your experience from the review that whatever you've done.
No, I actually only focus on malalignment.
Alright, take it. Not a problem. Okay. Yeah. I think that's about it. And did any of those studies allude to radiation exposure in either of the techniques while performing? Now that the results are, we know what the results are.
I didn't particularly poke into that because.
No problem. So it was all to do with one. Good, good.
You mentioned about the rotational alignment in the. Do we have time or?
No, I think we are good. There are some 7, 8, 2, 3, 4, 5, 6, 7,
Okay.
10.
Yeah, we are kind of
If ask
overshooting.
one
Yeah.
question each, that should be enough, no?
Yeah.
Okay.
Yeah, go ahead.
Thanks, Pratik. Thank you very much. Good
Thank
presentation.
you.
Thank you very much.
Good, good.
Okay, thank you, Pratik. I'll invite Dr. Nitish to please share his presentation now.
Yes, sir. Am I audible now, sir?
Yeah, you're audible. Please share. Okay, we can see your presentation. Go into presentation mode and start. Start the
Yes.
slideshow.
Yes. Good evening, everyone, my colleagues and seniors. So today I'm going to present the topic on open tibia shaft fractures, Gustilo-Anderson, type 2 to 3A, a comparison between early intramedullary nailing versus stage nailing after external fixation. So this is the Gustilo-Anderson classification, which everyone is well versed of. So today we are going to focus on type 2, which includes moderate to high level of contamination. So this is the prospective cohort study, which studies mainly on the effect of treatment delays. Like, we have any of the problem related to fracture related infection in open tibia shaft fracture? Like, why we are concerned about, should we do immediate early intramedullary nailing or should we wait for some time? So 5 parameters. So first was antibiotic administration within less than 3 hours to more than 3 hours. Second was primary debridement in OT within 24 hours or more than 24 hours. Third was definitive skeletal stabilization within 5 days or more than 5 days. And also soft tissues reconstruction. The time to union was also recorded. So according to British Association of Plastic Reconstructive and Aesthetic guidelines, it should be within the 3 hours of presentation. Primary debridement, similarly, earlier it was said that golden extended period is 6 hours of presentation, we should debride. But over a time, there has been studies which shows like proper debridement, even if taken within the OT settings, and if it's within 24 hours, it is equally good debridement. Then skeletal stabilization, we know because it prevents further soft tissue injury, limits bacterial spread, and improves blood flow. Then patients were divided into 2 groups, differentiating between who underwent 2 or fewer formal debridements.
Dr.
And
Nitish,
who
your
underwent more
Siri
than
is
2
open, I
procedures.
guess.
So this was a study, which were the
Dr.
parameters
Nitish.
studied, all the 5 parameters.
Yeah.
So finally, 9.14% of the patients that have definitive
Nitish.
soft tissue,
Dr. Nitish, can you
or
hear
definitive
us?
skeletal fixation, both in the same sitting. had
No, I don't think he can
lesser
hear.
complications as compared to those who had skeletal stabilization
He can't hear
after
us.
soft tissue coverage.
It's quite surprising, no?
And what about fracture-related infections? These are according to AO guidelines, and these are the fracture-related
I think his
infections
screen also has
which
gone.
can be checked by various.
We'll start with the next one.
Nitish, can you hear
I
us?
think
We've been trying to
no,
interrupt
he's
for a long
In
time.
this SPECT CT image specifically, which is WBC scintigraphy, we can see distal locking bolt has a site of infection. Similarly, microbiology, molecular biology.
we have to start with the
Like,
next one.
Yeah, Ashok, yeah. So next one is a better
Nitish, can
option.
you hear us?
yes, sir. No, I was not able to hear you, sir.
Yeah, your presentation was on with Siri. So your Siri screen was seen.
Uh, I'm sorry. This is also again, sir, the same thing.
Now, can you share your presentation again
5 minutes
and
we are trying
start
to
with the
interrupt.
second or third slide?
This one, sir.
Can't see
Share
the
your
slide.
screen.
Um,
Yeah, this slide is fine.
Yeah, just go to play mode.
Now is it okay, sir?
Yeah,
Yes, okay, you can start.
Should I start again, sir?
no, this is fine.
It's
This,
okay.
yes, slide is okay.
So these were the 5 parameters noted, which included antibiotic administration, primary debridement in OT, definitive skeletal stabilization, and soft tissues reconstruction. Also, the time to union was recorded. So according to BAPRA's class guidelines, within 3 hours, the earlier the better. And according to NICE guidelines, which is from 2016, which say even while shifting the patient, if we administered antibiotics, this is better. Similarly, second parameter was primary debridement. Traditionally, it was called the golden rule. Within 6 hours of presentation, primary debridement should be done of open fractures. But with new studies, literature shows that even if done in proper by experienced surgeon, proper debridement in OT is equally good enough. Then skeletal stabilization is important because it prevents further soft tissue injury, limits bacterial spread, improves blood flow, and it reduces the edema. These were the 5 parameters which were studied. So it showed around 9.14% of the patients that had definitive soft tissue closure, uh, but both had the same setting or definitive tissue reconstruction before definitive stabilization by the nailing. It was better results as compared to when patient who underwent definitive fixation followed by soft tissue. These are the fracture-related infection which can be checked by various parameters like clinical parameters, lab parameters, medical imaging, uh, microbiology, molecular biology, and histopathology. So my main topic today was risk of infection and conversion time from external fixator or any of the external fixation device to definitive fixation in open tibia fractures from type 2 to type 3A. So according to this study by Vazan et al., so they divided all the 55 patients into 4 groups. Group A was less than 12 days of conversion. Group B was 12 to 14 days of conversion. Group C 25 to 36, and Group 4 was more than 36 days of conversion. Like this was conversion from external to internal medullary nailing fixation. So according to this group, infection rate was gradually increasing. The more we delay the conversion rate, the more there was a risk of infection. Similarly, according to Bhandari et al., a shorter duration, less than 28 days of external fixation decreases the overall risk infection, and union was also 92%. Similarly, other studies showed there should be a fixed timeline when we should convert from external fixation to intramedullary nailing. Why? Because of various parameters like pin tract related infections. Uh, Therefore, after excluding pin tract infection, a protocol should be made which comprises curettage, debridement, and irrigation of pins. So what we have to come further was like if we want to do immediately as soon as the patient comes, what can we do? So there were comparative studies of gentamicin coded intramedullary locking nailing versus regular interlocking nailing in Castillo type 1 and type 2 open fractures. Similarly, gentamicin coding was done in other various studies. So they showed a follow-up of 6 weeks to 6 months. Like they showed the union rate and CRP count, ESR count, and hemoglobin levels. So this showed pre-operative to post-operative comparison. Gradually, ESR CRP was better in gentamicin-coated and intramedullary nailing as compared to control group, which included a non-coated intramedullary nails. So, there was some study on comparison of unreamed interlocking nailing and external fixation in open tibia shaft fracture, where according to some surgeons, if we don't do reaming, the chances of infection rate will be decreased. Also, we can do single stage management of Gastillo-Anderson type 3A or B fixation, which uses the fix and cover protocol, which includes nailing in the same setting as flap with the fasciocutaneous flap. So according to this, when we try to convert from external fixation to intramedullary nailing, what is the time of surgical treatment? It includes the pin to nail overlap, pin tract infection, and fracture-related infections. So one study was external fixation to intramedullary nailing for femoral and tibial fractures. They checked for 11 years cohort study at one trauma center. So they showed when fixation method was intramedullary nailing, time to union was around 22 weeks. These were the studies. So today's take-home message is decision to close an open fracture acutely is often made on the treating surgeon because of there are various parameters which we want to see if how the hospital setting is. And according to Rajsekharan et al., debridement within 12 hours is better to convert into intramedullary nailing. No skin loss is there primarily or secondarily during debridement. Skin approximation possible without tension. No farmier or gutter contamination. Debridement performed to satisfaction of the group, and there is no vascular insufficiency. So these were the parameters which we can see that we want to convert from extramedullary any of the extra fixation to intramedullary nailing as soon as possible. Thank you, sir.
Thank you, Dr. Nitish. I'll invite the judges for questions. Satish, sir, you can start.
So,
Yeah, I'll invite the judges for questions. Thanks, Dr. Nitish.
hello.
Satish, sir, you can
Hello.
start.
Yeah. So, Dr. Nitish, again, a nice presentation. You quoted one major study where they evaluated early intervention versus the CRP levels and the blood markers and time to union, right?
Yes, sir.
Okay. So, in that evaluation, that study, which was discussed many times earlier also, there is no role of no inclusion of the definable FRI. The
Right,
FRI
sir.
definition, the fracture related infection definitions,
Yes,
which
sir.
has 4 criteria. Uh,
Yes, sir.
the the obvious ones are the fistula, sinus, and other things. But
Yes,
in
sir.
your knowledge of all the cases that you have gone through, when they do early intervention with or without soft tissue coverage, which are the earliest signs of FRI that uh, have been documented or have been rated as the warning signals or something?
So I feel clinical evaluation is the one of the most important, as told by our professors as well. Like we see the condition of the skin wound.
Hmm.
If it's like red erythema is there, rubor color, dolor is there, we try to avoid any intramedullary intervention. These are the parameters. Like if redness is there, swelling is there, or any obvious discharge, pus discharge is there, we try to avoid the intramedullary fixation, and we can wait once the soft tissue heals.
Did you quoted the paper from Ganga Rajshekharan?
Yes, sir.
which they have published, I think, last year about
Yes, sir.
early intervention with soft tissue coverage, the Ganga scoring system guideline.
Yes, sir.
In those guidelines, they have mentioned some other diagnostic criteria for early infection FRI diagnosis. Did you go through that?
Uh, yes, sir. I have read about the Ganga scoring. It was actually published because in Gustilo-Anderson type 3B, it was not clearly mentioned like what is the definition of type 3B. So they defined four parameters, which include soft tissue, bone, muscle cover. So these were the parameters, but I'm not sure about the lab parameters which they discussed.
Sachin?
Yeah. I'll just ask few questions because we are maybe lack of time. The skin closure, you said you're going to do the skin closure every time. Can you just highlight on this skin closure on the wound basic question?
Yes, sir. Actually, there were different articles which I went through. There were different say on by everything. Like some studies showed that any of the flaps done at the same sitting of any of the fixation with gastrocnemius slab or any of the slab after proper debridement gives good results. But similarly, same in different settings, some studies show that we can wait for some time when the soft tissue properly heals. Then only we should go for any of the soft tissue coverage and not do at the same sitting.
Okay, Ashish, go ahead.
Yeah, Nitish. So all these studies that you quoted, you saw the previous presentation also. He quoted a lot of systematic reviews. And did you have any randomized control trials in this topic? And what these? I mean, what was the common factor through all these studies? Were they for all from type 1 or a level 1 trauma center or a very high volume trauma center?
Yes, sir. One study was done in KMC Manipal itself, uh,
Mm-hmm.
which they compared and randomized the open tibia fractures with gentamicin coated nailings and without gentamicin coated, which I have quoted in my presentation as well. So they found out there was better results with gentamicin coated uh, nailing fixation uh, within the first 6 months and not further on. There was no effect on union, but yes, soft tissue coverage also and early soft tissue infections were better with gentamicin coated nails.
Right. So, to conclude from your presentation, what is the take home for yourself when you practice? Let's say you have an open injury, you put an external fixator in the middle of the night, or let's say next day morning. What is the time that you're looking for when you're going to tell the patient ki itne din ke baad we are going to change to an internal fixation or a fixation and flap or fixation and cover if required?
Uh, According to traditional teachings, there was 6 to 8 days, which
No,
I
no, I
was.
mean from your presentation.
Sir, there have been studies which showed that done on the same sitting within the first 24 hours, fixation as well as the soft tissue coverage, it gives equally good results. We don't have to wait for 1 week or something. We can do if the surgeon is sure about the ruling out the infection, then you can go ahead with nailing in type 2 and type 3 as well.
Okay.
Yeah. So Nitish, I had a
Yes, sir.
comment and a question which I think Ashish has covered. You did a lot of study as far as all the various things were concerned, but the presentation was really crowded. I couldn't really make out on individual slides what was the conclusion which you had at the end. And even at the end of the presentation, finally, your take-home message is from one paper only, from Dr. Rajsekharan's paper. The other
Yes, sir.
conclusions were not really summarized well. So
Yes, sir.
here at the end of the presentation, you are left with the question what Ashish asked you. Ultimately, what is the conclusion? When do you do an intramedullary or when do you do an internal fixation after managing compound injury? That question was still open, and Ashish had to actually ask you to get an answer out of it.
Yes, sir. I went through two meta-analysis which showed the which was done with checking out all the randomized control studies, which showed that if the surgeon is confident enough of the soft tissue management, the primary fixation as well as soft tissue coverage can be done in type 2 and type 3A tibia fractures.
All right. Thank you.
Sure, sir. Thank you.
Thank you very much, Nitish. I'll invite the next participant, Dr. Varun. Varun, please share your presentation. We can start. After that, we'll have Dr. Shubham.
Yes, sir. Just sharing my presentation.
Yeah. We can see your presentation. We can hear you. We can start.
Yes, sir. Ma'am.
Yeah, go ahead.
Good evening, sir. Good evening, my colleagues and respective judges. I want to thank Bombay Orthopaedic Society for giving me this opportunity. My topic is on non-displaced scaphoid-based fractures, percutaneous screw fixation versus cast immobilization, return to function. So we all know that the scaphoid is the most commonly fractured carpal bone in active adults. Even non-displaced waist fractures can cause major loss of wrist function. Cast treatment gives good union rates, but also there is delayed return to function. Screw fixation helps with early mobility and faster union. My objective was to compare percutaneous screw fixation with cast immobilization in non-displaced scaphoid waist fractures, their return to function, union, and complications. So, what is exactly a non-displaced scaphoid waist fracture? An acute fracture through the waist of the scaphoid, less than 1 millimeter gap or step on CT or dedicated X-rays, no deformity or combination, stable alignment. This represents a stable pattern which can be treated by cast or percutaneous screw. This was taken from the EFORT Open Review 2020 guidelines of acute scaphoid waist non-displaced fracture management. Uh, this was my methodology. Inclusion criteria, acute non-displaced scaphoid waist fractures. Study types taken in inclusion were randomized controlled trials, meta-analysis, systematic reviews, and my database was PubMed, Scopus, and Google Scholar. So coming to the evolution of evidence, in 2001, we have a landmark paper by Bond et al., which was the first randomized control trial comparing percutaneous fixation with cast in non-displaced fractures. It showed that the percutaneous group fixation had early fixation, faster union, and early return to recovery. In 2001, another randomized control trial by Adolphson et al. Confirmed this early functional benefit of the percutaneous screw fixation. However, in 2015 to 2018, we had several meta-analyses showing that although the percutaneous screw fixation group was giving a short-term gain, that was the faster union and early return to work, the long-term functional outcome at 1 year of cast and percutaneous screw fixation was the same. So in 2020, we had the SWIFT trial, which was the scaphoid waist internal fixation fracture trial. It was a 439 patients randomized controlled trial, um, which showed that at 1 year, there was no difference in functional outcome of the cast group and the percutaneous fixation group. The DASH scores and the patient-related wrist evaluation scores were the same. However, the percutaneous fixation group had a higher reoperation rate and increased cost due to surgery. And coming to 22 to 2025, we have several meta-analyses in which the CT scan was done for all non-displaced scaphoid fractures, and treatment was based on that. Over here, again, the screw showed faster union and return to work, and the 1 year out functional outcome was the same of both the cast and the screw fixation. So we've gone from, according to the literature, from operative to casting all, and in 2020 the SWIFT trial showed us there was no difference in functional outcome at 1 year, and now the evidence is showing us that we should get a CT scan, see the stability, and then operate according to the demand of the patient. Coming to the short-term outcomes, the percutaneous screw versus cast immobilization, the union rate was slightly higher in the percutaneous screw group. The time to union was 4 weeks faster in the percutaneous screw group. Return to work and sport was 5 weeks earlier in the percutaneous screw fixation group. Grip strength was 100% at 6 weeks in the percutaneous screw group. Mobilization time was significantly less. The non-union rate was also 1.6% compared to 7.1% in the cast group. However, there were hardware irritation issues with the percutaneous screw fixation group. And coming to the long-term outcomes and the pragmatic view, the one-year outcome, according to Johnson et al., the patient reported function in which we take the DASH score and the patient-related wrist evaluation score showed no significant change at 1 year of percutaneous screw fixation versus cast immobilization. Even coming to the SWIFT trial, which was a 439 patient randomized control trial, showed no difference again at 1 year in the DASH scores and the patient-related wrist evaluation scores. The union rate was same, that is 90 to 95% in both the percutaneous screw fixation group and the cast immobilization group. However, the reoperation rate was higher in the percutaneous screw fixation group, and also the complication rate due to surgery was higher in the percutaneous screw fixation group. So after this, we do know at 1 year, function and union are essentially the same. However, surgery costs more and generates more reoperations. Coming to athletes and high demand individuals, they lose the most from long-term immobilization. Multiple randomized control trials showed that return to work after fixation was 6 to 8 weeks compared to 12 weeks with the cast. Meta-analysis by Goffin, which was a 160 patient study, all of them were athletes, showed that return to sports in 7 weeks versus 9.6 weeks. Wolson 2025 also showed that return to work with 5 weeks in the percutaneous screw fixation group. So the takeaway from this is early screw fixation gives faster return and higher union is justified in athletes and heavy demand patients. So my consensus and what the future is from all my data which I've presented till now is that CT defines the stability for non-displaced scaphoid fractures. We have Clemenson et al. E4 2020 and Wolson 2025, where we should get a CT scan for all non-displaced fractures. Anything less than 0.5 mm can be casted. Anything more than 1.5 mm definitely requires internal fixation, but the displacement between 0.5 to 1.5 mm requires selective fixation. These cases should be judged on whether the patient is an athlete or a high demand individual. CT guided conservative success. Greval 2016 had a study in which truly stable fractures less than 0.5 mm on a CT did really well with casting, had a 99% union at 7 to 8 weeks. Fixation definitely gives faster recovery and faster return to function, but has complications. And the functional outcome at the end of 1 year is the same between both the cast fixation and the percutaneous screw fixation. So these are my references. Thank you.
Thank you very much. I'll invite the judges for questions. Nitish, sir, you can start.
Yeah, again, nice talk, Varun.
Yes, sir.
The waist fractures have been further classified into proximal waist and distal waist fracture,
Yes, sir.
and the success outcomes are different. You have
Yes,
not
sir.
mentioned any study about that, the figures. So, what is your experience about that?
Yes, sir. So the Clemenson et al. Gave a criteria of which we get a CT scan for our waist fracture. So anything less than 0.5, whether it is a slightly proximal or distal waist, if it's less than 0.5, these can be casted. If it is more than 1.5, these definitely require internal fixation, and anything between 0.5 to 1.5, depending on the patient's demand, can be either fixed or casted. So these included the proximal or distal waist fractures, but the displacement is based on the CT scan.
No, but other things being normal, are the union weights different in a proximal waist and a distal waist fracture?
So that again comes
Hello.
based on the displacement, sir.
Okay. Thank you.
Varun, hi, Dr. Ashish here. Good presentation, very crisp
Yes,
and
sir. Thank you, sir.
very well researched. I just want to ask, based on your presentation, if a surgeon, orthopedic surgeon comes to you
Yes, sir.
with a scaphoid waist fracture, which is not very displaced, where will you classify him and what will you offer him? He
Sir,
says,
I would
Doctor, aap decide karo.
sir, I would get a CT scan first.
Yeah,
First thing I would
as I said, it's not displaced, less than 0.5 millimeters. An orthopedic surgeon, he said that, you decide what you're going to offer me.
for casting, because these are truly stable scaphoid fractures according to Clemenson, and they have shown a 99% union rate in even with 6 weeks of immobilization only with a short arm cast, the short arm thumb spiker. So the literature for the less than 0.5 one strongly shows that these fractures will unite even with a shorter immobilization period. So I
So this
would go for that.
Yeah, so this Clemenson study was based on what? Was it a randomized control trial? Was it a single surgeon study or was it a meta-analysis?
It's a randomized control trial, and it took into account a CT-based study in which any of the non-displaced fractures less than 0.5 were casted, and anything more than 1.5 internal fixation. The only issue was the group between 0.5 to 1.5 where depending on the patient's demand and if they were athletes, they would go for fixation.
Okay.
Yes, sir.
This is published where?
Clemenson et al. E4 2020.
E4.
Varun, good presentation. I have no questions for you. I think your presentation is quite clear and the conclusion also quite clear.
Yes, sir. Thank you, sir.
Thank you very much. Any other questions, Dhar sir, Sachin sir?
And no questions. Good presentation.
Var-
Was up to the point. Yeah, go ahead.
So, Varun, does any of this study define the failure of conservative treatment as far as? At what point would you say that your conservative treatment is not working?
Sir, we should definitely, of course, have to get serial X-rays. There were a few studies which showed that I would go back to the SWIFT trial, which was the largest randomized control trial of 439 patients, out of which 210 patients were treated conservatively. So out of those 210 patients, only 7 patients had required a surgery for non-union. So the success rate with the conservative management is very good. And also, sir, the SWIFT trial had taken patients up to less than 2 of displacement. So out of those 210 patients, only 7 patients required surgery who were treated conservatively. So success rate is higher than 90%.
Okay.
Yes.
Okay. Thank you, Dr. Varun. I'll invite
you,
Dr.
sir.
Shubham for sharing his presentation. Dr. Shubham, you can start.
Yes, sir. Am I audible, sir?
Yeah, you're audible. We can see your presentation. Play it. You're sharing the desktop probably. Share the presentation and then play it. Yeah, now play it. Should work now. At the top, you see the play thing.
Yeah. Can you see the screen, sir?
Yeah, we can see, we can hear you. You can start.
Yeah. Good evening, everyone. I'm Dr. Shubham Atal. My topic for today is operative versus non-operative management in pelvic lateral compression type 1 injury with complete sacral fractures. So lateral compression fractures are the pelvic fractures are the most common pelvic ring fractures involving the pubic rama fractures and sacral impaction injuries. Many patients after injury have functional decline. The elderly fragility fractures of pelvis carry 1-year mortality rate up to 27%. The management of lateral compression 1 injuries with complete sacral fractures is still debatable. Studies have demonstrated good long-term results with non-operative management, although surgical stabilization could improve early outcomes of pain, function, and rehabilitation time. For the research methodology, I've used the electronic database of PubMed and Google Scholar, relevant filters to search recent studies. Systematic reviews, RCTs, and meta-analysis were included. First study was the J.R. Verma et al., the systematic review published in 2022. 5 studies were included in the review of past 5 years. The study outcome was measured in terms of change in pain scores. All the studies reported decrease in pain scores after the surgery over the non-surgical groups. They concluded that surgical fixation positively correlated with reduced pain and time to mobilization in short-term follow-up. In long-term follow-up, no statistical difference in pain scores seen in different groups. No statistical difference in functional outcome or quality of living, and post-treatment complications was found. In another study by Gerard Slojan, which was a prospective clinical trial, included 95 patients of the lateral compression injuries, out of which 71% were LC1 injuries. Primary outcome was measured using the patient-reported pain scores and functional outcome over the Majid pelvis score. The outcome was analyzed at 12 and 52 weeks. We can see the patient characteristics. They subdivided the initial fracture displacement in two subgroups, less than 5 mm displacement and 5 to 10 mm displacement. The authors were the opinion that no difference in time to mobilization or discharge from the hospital in the treatment groups. The small improvement in pain and physical function at 3 months till 1 year in the surgical group. Larger benefit with surgical fixation was seen in patients with more than 5 mm fracture displacement in posterior pelvic ring. Joshua Perry conducted an international survey in which 19 international pelvic trauma surgeons completed a 45-question survey on management of pelvic ring injuries. The survey had 5 questions on cases including the LC1 type, LC3, APC3, vertical shear through sacrum and vertical shear through SI joint. The LC1 injury and combined VS injury through sacrum had no agreement on moderate or strong agreement on management guidelines among the surgeons. If we see the questions included, one of the questions was, is stress X-ray necessary to plan the treatment of this fracture? Of the 19 surgeons, 7 said yes and 12 said no. When asked if you will fix the fracture, only one of the surgeons said they will not fix the fracture, and rest 18 will either fix with anterior, posterior, both, or posterior first and decide later with anterior fixation if unstable. In a most recent study, which is the multi-center propensity matched analysis by Marchand Lucas, which was published in October 2025 on the stress positive compression fractures. The LC1 fracture that demonstrate dynamic instability, that is more than 1 centimeter displacement on lateral stress, are stress positive. It included 224 patients retrospectively, out of which 139 were operative and 85 non-operative. Outcomes were compared in terms of hospital stay, ambulatory distance, discharge to home and facility, unassisted ambulation at follow-up, and mortality. Operative group patients were ambulating unassisted at follow-ups. After propensity matching, operative group had lower mortality than non-operative group. Mortality was more in elder age group. Rest all other parameter has no statistical difference. Tucker Nicholas in his study included 43 patients. Operative group was less likely using assistive devices at 6 weeks and less likely to remain in a rehabilitation facility at 2 weeks. Less fracture displacement at follow-up. They also concluded that complications in both the groups were high and must be taken into consideration at patient counseling. In exclusively non-operative management of lateral compression injuries done by Joshua Perry, they said that stress X-ray displacement correlated with delayed operative fixation, time to rehabilitate, increased hospital stay, and opioid doses. The threshold displacement with maximum sensitivity and specificity for delayed fixation was at more than 10 mm. Occult instability was associated with rami comminution and not the complete sacral fracture, which has been used to judge the LC1 fracture stability. Coming to the last parameter, but which is very important parameter, that is the cost effectiveness. In a study by Soham Ghoshal, the authors evaluated the cost effectiveness of surgery versus non-surgical management. Outcomes were measured by brief pain scores and the Majid pelvis scores. At 2 weeks, surgery is cost effective with respect to pain scores. At 12 weeks, surgery is cost effective in respect to Majid pelvis score. We can conclude that for the patients whose lifestyle demands immediate pain relief and early mobilization, the surgical management is more cost effective. In the words of Dr. Penal and Tile on lateral compression pelvic injuries, the potential instability of an apparently innocent looking fracture is often unrecognized. To summarize, in long term, both surgical and conservative management gives comparable results. In short term, surgical fixation offers reduced pain scores, early mobilization and rehabilitation, and better quality of living. The lateral stress radiographs may be a deciding factor in the treatment modality. Most of the reference articles stated in the review were of international studies. In my opinion, more research focusing the Indian population demand need to be done. These are my references. Thank you for patience listening. Thank you, Bombay Orthopaedic Society, for giving us this opportunity.
Thank you very much. I'll invite the judges for questions.
I'll give it a pass for now. Ashish, would you like to ask?
Yeah, Shubham, good presentation. In any of the studies, did they attempt to differentiate between the younger patients and the elderly patients who were coming from nursing homes and who had polypharmacy and osteoporotic related fractures?
Yes, sir. So most of the studies which I included the non-fragility fracture groups, which were almost less than 60 years of age. So basically, most of the studies, if you see the first study, which was the meta-analysis, the mean age group was 42 years age group, like 40 to 50 years age group.
Okay. And have they differentiated on the modality of fixation, whether they have used a percutaneous screw or, I mean, any other
No,
modality?
sir. They don't have discriminated on the fixation methods. I have not studied the research on the surgical version also respect to a particular fixation, but most of the surgeons use posterior with anterior. If they want to use isolate, they use the posterior fixation.
Okay. And how many surgeries did on an average? I mean, did you study in their studies? Did it come across that patients who underwent surgery underwent on an average one surgery, or was it more than one surgery they had to undergo?
In one study, sir, it was that due to complications, so the surgical group had to undergo 7 more surgeries. Regarding that, in non surgical management, only one patient had a delayed surgery.
Okay. Thank you. Good presentation, Shubham.
Yeah, it was a good presentation, Shubham. Any of your studies talked about return to function after either surgery or conservative, which was faster, and whether these patients did return to their pre-injury occupations?
Yes, sir. 2 or 3 studies included the Majid pelvis score. So the Majid pelvis score has a 20 point for the working pre-working state and the post-working state. So most of the studies has reported a good to excellent outcome after surgical management. But if we see in the long term results, if we propensity match the age, everything, so at long term the results were almost same for surgical fixation or a conservative management.
Okay, thank you.
Yeah, Shubham, good presentation. I just want to know why you wanted to know the study on the Indian population. Like anything else, like you feel the morphology is going to change or something, like as you said, a lot of study definitely is more international studies.
So I
So
think there are multiple factors in India because first is the most last, which we think is the cost effectiveness that matters more in India, I guess. So I guess the cost of healthcare is more in the foreign countries than in the Indian countries. Most of the I think if we offer surgeries to the patient in the Indian scenario and compare it with results, so I guess surgical fixation will definitely have a better outcome in all the parameters than the non-conservative treatment. So I think the demands, the working style, the lifestyle, this all has a Indian population has a different needs than the foreign population. So I guess a dedicated Indian population study is needed. I was astonished to see that very few studies are published in India. Although we see a lot of this LC1 injuries in our routine practices at like, trauma centers and all.
okay, thank you.
Thank
So
you, Dr. Shubham.
sorry, incentive for you to start publishing, na?
Yes, actually, sir.
Thanks, Dr. Shubham. I'll invite Dr. Tushar to share his presentation.
Yeah. Good evening. Am I visible and audible?
Audible but not visible. Yeah, now it's better.
Yeah.
So you can start screen share and, slideshow and start.
Good evening to all. I am Tushar Lalchandani, and I will be talking about decision making in periprosthetic femur fractures around a well-fixed implant, whether to fix or to revise. I thank BOS for this opportunity, and I hope I can do justice to this very interesting topic. I have nothing to disclose. So the incidence of periprosthetic fractures is on the rise. Total hips being done in younger, more active patients and are elderly living longer. These fractures are now a major cause of revision arthroplasty. The Americans, Australians, and Swedish joint registries all report a rising trend in the incidence of periprosthetic fractures. For this narrative review, I searched for relevant studies on PubMed and Google Scholar and used meta-analysis, randomized control trials, multi-center trials, and data from repeated national joint registries in the last 10 years. My database search yielded 96 hits, and a total of 16 studies underwent a full article review. So we are all aware with the Vancouver classification system developed by Duncan and Masry in 1995. It is the most widely used classification for periprosthetic femur fractures. Type A is the fracture occurring in the trochanteric area, the greater trochanter or the lesser trochanter, which is recommended to be managed conservatively. Type B1 is a fracture around a well-fixed stem. B2 is a fracture around a loose stem. B3 is a fracture around a loose stem with poor bone stock. And type Cs are fractures which occur distal to the stem. So the core dilemma is, once we confirm stability, the question becomes whether to fix or to revise. As we can see in these preoperative X-rays, both fractures are classified as a Vancouver type B1 fracture with a stable stem. However, they respond well to different treatment modalities. This study by Leonardo and colleagues performed a finite element analysis of single lateral plate fixation in type B1 fractures. They developed 3 models representing poor, average, and good cortical thickness, transverse, short oblique, and long oblique fracture patterns, and fractures at the tip of the prosthesis, 4 millimeters and 14 millimeters below. These models were run through a finite element simulation analyzed for pattern of stress and fracture movement. They found that transverse fractures, poor bone stock, and increasing distance from the prosthesis tip led to the largest fracture displacement and stress on the plate. Warner and colleagues investigated the biomechanical characteristics of a single lateral plate compared to orthogonal plating in B1 fractures. 10 composite human femora were implanted with press-fit femurs, and B1 fractures were created, which were fixed with a single lateral plate or an additional LCP anteriorly. Each construct was cyclically loaded to failure in axial compression. Axial stiffness and number of cycles to failure was demonstrably higher in the dual plate construct. Hence, they claim it to be a viable treatment modalities in B1 fractures. The authors have recommended methods to manage this failure-prone subset of B1 fractures with the allograft strut augmentation, orthogonal plating, or a long stem revision. In clinical literature also, we can see similar outcomes with osteosynthesis in these fracture patterns. Excuse me. In retrospective analysis of femur fractures around well-fixed stems, this Korean group of surgeons in 2020, they have highlighted significant failure rates of nearly 40% in transverse B1 fractures at the tip as compared to oblique spiral and C-type fractures treated with a single lateral plate ORIS. They have recommended additional fixation is necessary from the get-go in these cases. Fink and Cassidy present independent large case series of failure of fixation in such fractures. They report good outcomes on treatment with revision arthroplasty. Chakravarti and colleagues highlight these fractures as a high-risk subset of B1 fractures. Laura and Shen, again, they have highlighted multiple failures of fixation in B1 fracture, and they also recommend revision arthroplasty as a viable treatment. In their literature review, Montanelli and colleagues recommend a holistic approach for decision making in B1 fractures, and they identify deficient medial cortex, transverse, and fractures at the tip of with fracture combination and fractures around the cemented stem as high risk for retention of the stem. This multi-center group of Japanese arthroplasty surgeons, they have presented their findings in 2020 after analysis of 15 years of data from 8 general hospitals. And apart from drawing similar conclusions as the previous literature, they present a sub-classification of B1 fractures based on location of the fracture and whether the femoral component is a press fit or a cemented implant. They recommend revision if the fracture involves the porous coating zone or the cement mantle, and osteosynthesis otherwise, if able to gain at least 6 cortices of purchase in both fracture fragments. Yasin and colleagues also subdivide B1 fractures in the revision arthroplasty group and the osteosynthesis group, highlighting a subset where stem revision should be considered as a viable treatment option. In the proceedings of the World Expert Meeting in Arthroplasty held in Istanbul in August 2024, they have given their consensus recommendation statement with the following. that transverse and short oblique fractures at or just below the tip of the prosthesis will yield suboptimal outcomes with a single plate osteosynthesis. They recommend to perform revision of the femoral component with a long press fit distally fixed stem. And if fixation is chosen by the surgeon, it should be augmented with an additional orthogonal plate or a cortical strut allograft. So finally the question arises, to fix or to revise. The surgeon must consider fracture pattern, whether it is a short oblique or a transverse fracture pattern. They must recognize that high stress leads to high failure. Fracture combination is another factor. Preoperative methods to confirm stability and intraoperative methods to confirm stability. The surgeon should also consider whether the prosthesis is a press fit or a cemented form. So take home may not actually be stable. And beware of transverse or short oblique fractures, poor bone stock, fractures at the prosthesis tip, and especially in cemented hips. Such fractures have a high risk of failure with a single lateral plate, and osteosynthesis with a dual plate or cortical allograft and revision arthroplasty are both viable options for periprosthetic fractures with a stable prosthesis. These are my references. Thank you all for patient listening.
Thank you very much. I'll invite
Thank
judges
you.
for questions. Satish, you can start.
So you mentioned about, am I audible?
Yes, sir.
Yes, you're audible.
You mentioned about 6 cortical holes in the proximal fragment. Are these 6 cortical holes the bicortical types, I mean 3 screws, or 6
That is,
unicortical screws in the single cortex screws? Are they equally
these are,
efficient?
sir, I have not come across any study which analyzes these both these factors, but most of the studies, there were 2 studies by Wood and the one by Okudera. These have highlighted that they have taken into account the single cortex purchase, and bicortical was taken into account as 2 cortices.
Okay, and when you say about the stud graft, is there any mention about fixation of the stud graft, any recommendations, or is it just on label?
Most of these studies have used a cable plate system.
Yeah, Ashish.
Yeah, Tushar, so you are quoting these studies. Apart from the consensus expert group study from Istanbul, before that, the studies are you quoting? Which years are these published in? How many years back are you going?
I have restricted myself to last 10 years, sir.
Okay. So in the last 10 years, you have found that there are people who are still using the cortical allografts and a plate.
Yes, sir.
Okay. Okay, that's all for me.
So,
Presentation.
Tushar, any studies related to whether the stem was cemented, uncemented, which required, which did better with revision versus fixation in a cemented stem?
Sir, most of these studies, they have taken into account cemented stems as being higher at risk for instability, and they recommend that they not be classified as B1 uh, on only radiographic appearance. Some authors are also routinely checking prosthesis stability intraoperatively. And they have claimed that nearly 20% of their fractures, which were initially classified as B1, and most of those are cemented stems, they turn out to be B2 intraoperatively. So I can conclude that a high rate of failure for B1 fractures can also be attributed to miscategorization as B1. They may be loose prosthesis.
So they would recommend that if I have a periprosthetic fracture in a cemented stem, you are likely to revise it rather than fix it.
Yeah. Yes, sir.
And no questions from my side. Good presentation.
Thanks.
Okay, sir. So thank you, Dr. Tushar. I'll invite
Thank
Dr. Dhruvi for a presentation. You can start sharing your presentation, Dr. Dhruvi.
Can I start, sir?
Yeah, you can start. Go into slideshow mode. Okay.
A very good evening to one and all. I thank the
Just a
Bombay
minute.
Orthopedic.
Just a minute, Dhruvi.
Yes, sir.
Can you see the camera images on the side panel of your screen?
Yes, sir.
Yeah, just minimize that or take it on the side.
Okay.
Just drag it on the side. Okay,
Yes,
that's
sir.
fine. And on the top, you can see the controls
Yes, sir.
of Zoom. Just move it up or try to bring it down maybe. Just drag it down.
Yes, sir.
No, it is still up because it is coming on your screen. Can you drag that down or take it on the side
Yes, sir.
if possible?
Done.
Yeah, this is fine. This is much better. You can start now.
Okay. Good evening to one and all. I thank the Bombay Orthopaedic Society for giving me this opportunity to present today. The topic that I'm going to be presenting is displaced midshaft clavicle fractures, plate fixation or intramedullary nailing. Which is better? Let's find out. This is the brief overview of the topics that I'm going to be covering today. The data and insights generated in the presentation are from the following studies. Clavicle fractures amount for 2.6 to 4% of total fractures, out of which mid-shaft clavicle fractures account for 80% of the total fractures, and these comprise of 44% of the shoulder girdle injuries. Now let's review the anatomy of the clavicle once. It is a unique S-shaped bone which is located horizontally across the shoulder girdle, has a thin cross-sectional area, and has high bending and torsional forces, particularly in the mid shaft. It observes a bimodal age distribution, out of which 63% young males are affected every year. The objective of my study today is to elaborate on patient-reported outcomes and analyze the functional outcomes across both the techniques of plating as well as intramedullary nailing. Going back 15 years, this was a paper published in 2010 that noted the operative, non-operative management yielded as good results as surgical management. However, we have come a long way. Recent studies have proven that conservative management has maximum complications with respect to non-union ranging from 10 to 20% and malunion about 15%. And despite union, these patients complain of chronic shoulder pain, reduced range of motion, cosmetic deformity, and diminished functional outcomes. A noteworthy paper published in Korea in 2020 divided the midshaft clavicular fractures into three types, type A, B, and C, according to the fracture morphology. The assessment of functional outcomes in this paper as well as subsequent papers were done by standardized tools such as DASH scores, visual analog scale, and shoulder range of motion. Now, based on these AO classification, this paper very clearly highlights that there is no statistical significance in the pain score as well as functional DASH scores between 2 to 6 weeks in type A fractures and type B fractures. However, there is significant, statistically significant change noted in the 2 to 6 weeks period between the tense nail and the plating for the VAS scores and DASH scores for comminuted type C fractures. Now, coming to a detailed comparative functional outcomes across various meta-analysis and studies, Sharif et al. Published a paper in 2025 suggesting that plate fixation showed marginally superior functional recovery and had higher mean score on DASH and constant Morley scores, whereas all other meta-analysis and studies conducted reported no significant difference between the functional outcomes long-term between plate fixation and intramedullary nail. Coming to the comparative complication rates, the implant-related complications reported prominence to be the most common complication for plate fixation. However, plate implant failure was reported to be found in 10.5% of patients with intramedullary nailing. Skin irritation and implant migration have been dreaded complications of intramedullary nailing ranging from 20 to 20.4% and have been more frequent with nailing. However, refracture after implant removal was noted to be more common with plate fixation. Coming to soft tissue complications, hypertrophic scarring, skin numbness, supraclavicular nerve injury, and infection were found to be maximum with plate fixation as compared to the intramedullary nail rates. Non-union was found to be marginally higher in plate fixation as compared to nailing. However, shortening and angulation was found in maximum number of intramedullary nail patients, that is 24.5% reported. On the image on the left suggested the same. There was a patient with mid-shaft clavicular fracture that was treated with tense nailing, and subsequently at 6 weeks, this was noted to have shortened, and there was angulation with the protrusion of the nail at the entry point, and which was revised, and subsequently union was attained. The image in the front shows the functional outcome in mid-shaft clavicular fractures of two patients treated with nail as well as nail and plate respectively, and showed excellent union at 6 months follow-up.
Space-time, when gravity is strong, space-time is violently distorted, and so
the cosmetic satisfaction was found to be superior in intramedullary nail because of less invasiveness and better scar, and plate fixation showed greater incision length and cosmetic dissatisfaction. Pain relief was also found to be more better in intramedullary nail, and this data was statistically significant. The hardware-related discomfort was found in both plate and nail, with nail amounting to skin irritation and tenting at the entry point. However, patient satisfaction was still higher as compared to plate fixation. Return to activity was also noted to be faster and more with intramedullary nail. However, radiological findings suggested that malunion and angulation are one of the most common complications of intramedullary nail, especially if put in multifragmentary type C fractures. Plate prominence was found to be 4.34 times higher as compared to nail, and long-term union was found by several meta-analyses suggestive that there was no statistically significant difference in scores like DASH or constant Morley, and they had comparable functional outcomes. The clinical takeaway of this would be that both techniques, nailing as well as plate fixation, provide excellent long-term functional recovery and very high union rates, but intramedullary nailing is associated with advantages such as less invasiveness, better cosmetic results, high patient satisfaction at the cost of malunion or angulation risk and skin irritation or tenting at the entry point. Whereas plate fixation provides robust biomechanical and rotational stability, is a gold standard for complex segmental comminuted fractures at the cost of higher incidence of implant prominence, large scars, cosmetic dissatisfaction, and infection. I would like to conclude by saying that both techniques are at the discretion of the surgeon. However, depending on the patient factors and specific fracture morphology, the decision has to be made. Thank you.
Thank you very much. I'll invite the judges for questions. Satish sir, you can start. You can stop sharing your presentation.
Dhruvi, really interesting topic and well concise. Two quick questions. So after all this, if you were to treat a type C middle third fracture, comminuted, what would be your choice?
So my choice would be to go ahead with a plate fixation.
Why?
Because as per the
All
studies
your
and
complications
literature,
are higher in a plate.
so as per literature, intramedullary nailing has not given satisfactory results both in terms of the pain scores as well as the functional dash scores in the long term, which is why I would prefer plating instead.
So of the 4 parameters you listed in the end, return to sports was higher in nail, patient satisfaction was higher in nail, except for that 24.5% chance of malunion and angulation.
Yes, sir.
All other things were good.
Yes, sir. But still, considering the fracture morphology, sir, type C fractures are indicative of plate fixation.
And secondly, this 24.5% angulation, was it clinically significant? Because that is the reason you're operating. If you end up having the same thing, it is not acceptable. So was it clinically acceptable? Was it clinically significant? The angulation and the magnitude.
Yes, sir, it was clinically significant in all patients. Now, that could be because of functional problem or cosmetic deformity, but the angulation was significant.
Dhruvi, in any of your Dhruvi, in any of your studies, nails which failed, how many were converted into plates? What was the salvage for a failed nail versus a salvage for a failed plate?
Sir, in one study that I saw in Korea, they have converted the failed nails into plates. There were 100 patients that were operated upon, out of which 49 were nailed, and about 10 to 12 patients had reportedly failed in the nail, and these were converted back into plates.
Thank you.
Dhruvi, good presentation. Actually, I want to ask you, in your studies, you have not mentioned the nailing was done in all closed or it is done open?
Closed, sir. All of them were
Or
done
everything?
closed.
None of them were open.
None of them were open, sir.
Okay. And what was the entry point?
At the sternoclavicular, at the medial sternoclavicular
Okay.
joint.
अपनी माँ पे जाती है लेकिन माँ अगर अनुपमा जी जैसी हो ना
Somebody's mobile.
Dhar, sir.
Okay.
Right, Dhruvi, yeah, so good presentation, very concise presentation. Has anyone compared different types of nails, or they have all used TENS nails for their surgeries?
So I did try to look up different types of nails if they've found, but I only found literature using ESIN and TENS nails.
Okay.
Dr. Gadegune has got literature on his nail,
Yeah.
the screw nail, and it is internationally published. It's a good publication. Should have been included in this.
Yeah.
And does the fracture pattern decides against the nail and plate?
Yes, sir. Based on type A and type B, fractures can be plated or nailed according to the functional outcome and the expectation of the patient, but type C fractures and comminuted displaced fractures ideal to be plated.
Okay.
Thank you.
Thank you, sir.
Okay. Thank you very much.
Thank
you,
you.
sir.
I think that's the last candidate for today. And I'll invite Ashish for vote of thanks. Thank you, Dhruvi.
Thank you very much, Ashok, and thank you everyone who participated. And actually, you have done a very, very good job. I mean, amongst all the presentations that I've seen, it's really difficult to mark the one person over the other. But all of you have done a good job of researching the articles and very good presentation, which is what the intention of this whole BOS Rising Star was. So I would like to thank Dr. Neeraj Bijlani and my dear friend Dr. Ashok Shyam for sort of having taken the initiative and taking this to conclusion. There's a lot of hard work that goes on behind the scenes, right from the thought process to inviting applications to getting the judges and marking system. So thank you very much, guys, for that. Thank you, Maharishi from OrthoTV. And thank you very much, Dr. Dhar, sir, for constantly encouraging us and pushing us to do that. And my co-judges and today, Dr. Satish Mutha, Dr. Harshad Argekar, and Dr. Sachin Kale. Thank you very much. And we all
Thank you,
to
Ashish.
see you.
Thank you.
Tomorrow is the next session of the trauma, right? Yeah.
Yes.
So the people who participated today can log in tomorrow, just see how the others are also presenting, and maybe you can take a couple of ideas from their presentations also. So wish you all the best to qualify for the next round, and let's hope to see you, most of you, over there. And I would also like to invite you for YROC. Of course, you will have to come to YROC to see the next round, but also the Bombay Orthopaedic Society Sports Day, which is just around the corner. The last day for application is 15th of November. So by all means, we would want everyone to participate and just be a part of our society. Thank you very much.
Ashish, before you conclude, some housekeeping questions. Those who are not presented today will not present tomorrow, or they are to be.
No, they will not present tomorrow.
So tomorrow you have different set of 10 people.
Different set of people. Yes.
So ये mark list, where do you send this mark list which you marked now?
You can send me today itself. Take a photo and send it.
ठीक, all right. Thank you.
And the same judges are there tomorrow also.
Sorry?
हम लोग को ही judge करने हैं कल भी ना?
हाँ, but दूसरा है ना, different name.
दूसरा है.
Different people.
So these four are absent. These four are absent.
Yes, sir.
Yeah.
Deepak Maley, Ayush Gupta, Tushar Jethi.
Well, I don't know to be disappointed or thank them because before